Good morning, everybody, and welcome to Day 2 of the World Congress of Pharmacology. I'm Professor Sir Mark Caulfield, and I'm chairing this session with my friend here, Munir Pirmohamed, who is doing the heavy lifting. And it's great to see so many of you first thing in the morning. If there is a fire alarm, we're not expecting it, so please leave by the exits. There are numbered microphones around the room. If you do want to ask a question of Munir at the end, then we'll have some time for questions, and just come to one of the microphones. I'll signal to you and then say your name and where you're from so we know who you are, and then the session will end around 9:20. After that, there will be a brief refreshment break, but other things start again at 9:45. So thank you for coming. It's my pleasure to introduce Professor Sir Munir Pirmohamed, who is the David Weatherall Chair of Medicine at the University of Liverpool, where he runs the Wolfson Centre, and he has also got a key role in the Medicines and Healthcare Regulatory Products Agency, and he's going to talk to us today about pharmacogenomics, clinical pharmacology and implementation, progress and barriers. Munir, you have the floor.
Thank you very much, Mark, and thanks very much for the invitation. Great to be at the World Congress, and many congratulations to David and Amrita and the BPS team for hosting such a fantastic conference so far. Great pleasure to be here, and in this keynote, I want to combine the principles of clinical pharmacology, not just pharmacogenomics, in terms of provide you some aspects in terms of inter-individual variability. I am going to provide you with some unpublished data in many segments of my talk, because I think that's important in a scientific talk. So let me just start off with variability in drug response. This is an area that I worked in for a long time, and Garrett Fitzgerald in his opening session mentioned this as an important area for clinical pharmacology. And if you look at variability in drug response, it affects both efficacy and safety. And Alan Roses, in a talk in London, said that 90% of drugs only work in 30 to 50% of patients. Now, people may argue about the veracity of that data, but if you look at any clinical trial, you'll find some people respond well, some people respond moderately well, other people don't respond at all. And we've known about this variability in efficacy for a long time, many different disease areas. And if you look at something like depression, where there are many drugs which are prescribed in primary care, a person may be given antidepressant, it takes 3 months to assess response, and then another 3 months to assess response to second drug, etc. So a person may be on drugs for 12 months without any response at all because of the kind of approach that we have to use at the moment. In terms of safety, work that we've undertaken in some of the biggest studies in the world have shown that 6.5% of all admissions to our hospitals are due to adverse drug reactions. And these can lead to, unfortunately, deaths of patients, but also hospital bed usage as well. So at the moment, in the UK National Health Service, there are at least 10 800-bed hospitals, that's 8,000 beds, occupied by patients with adverse drug reactions. And clearly, we are facing the burden of polypharmacy in our clinical practice now. The patients particularly are facing the burden. And this report, which was published by NHS England, led by the Chief Pharmaceutical Officer at the time, Keith Ridge, highlighted that 15% of patients in the NHS are on 5 or more medicines, 7% are more than 8. And those who are elderly, those with disabilities, those from minority ethnic backgrounds are disproportionately affected by this polypharmacy burden. But this is not just a UK phenomenon, it's a phenomenon seen in many countries. As you can see, data on one side of the slide, which highlights the number of countries where the polypharmacy burden has been increasing over the years. And that is unfortunately associated with increased risk of adverse drug reactions and drug-drug interactions. This is a paper we published just last year, looking at particularly patients with multimorbidity being admitted to hospital for over 1 month. And one of our clinical pharmacology registrars was stationed in the acute medicine unit and was seeing every patient and assessing them using a deep phenotype approach. And what he found was that ADRs accounted for 16.5% of hospital admissions. And as you would expect, those who take more medicines, those who have more comorbidities are at higher risk. 40% of these were possibly or probably avoidable adverse drug reactions. This mortality rate, 0.34%, doesn't seem very much, but actually if you extrapolate that to the total number of people being admitted, it comes to a very large number. And people stay in hospital for 6 days, and when we extrapolated this to the NHS England bed base, we calculated that at the moment this costs the NHS about £2.21 billion per annum. So what are the reasons for variability in drug response? Well, there are many different reasons, and some of them are listed here, not all of them. Some of them are listed here, and some of these we do take into account. For example, drug interactions. We have the BNF plus other drug interaction resources where we should be taking them into account, but we know that it doesn't always happen. Perhaps we take renal function monitoring into account and change the doses of drugs when somebody has impaired renal function, but again, we know that's not always implemented properly. If you look at weight, we don't even know with certain drugs whether we should be using the actual body weight, the total body weight, ideal body weight, or body surface area, because those studies just have not been done. And then there is the issue of sex as well. We just do not take that into account. I'm just going to show you one slide on sex differences. If you look at preclinical studies, many preclinical studies in the past have just used male rodent species in terms of assessing drugs, in terms of metabolism and disposition. It is now, if you apply to the UK Medical Research Council, it is mandatory to make sure that you have the sort of two sexes represented in preclinical studies that you undertake. In clinical trials, that's been a problem. It is being addressed, but it has been a problem. There has been underrepresentation of females. For most drugs, there is no sex-stratified dosing, and we know from various studies which have been undertaken that women are at 1.5 to 1.7-fold greater risk of ADRs. Part of this may be due to the different diseases that women suffer, but there are important pharmacological differences which are listed on the slide there: lower lean body mass, volume of distribution, etc., and effects on metabolism, but also pharmacodynamic differences as well. And this particular study was able to look at the correlation between pharmacokinetics and ADRs, and you could see there was a remarkable correlation for 7 particular drugs. Men were higher risk of ADRs because the PK was different than in women, but actually in women there was a much greater number of studies which showed higher PK changes leading to higher rate of adverse drug reactions. And I think women are hard done to in terms of the pharmacological studies we undertake and so on, and it is important, something that we need to think about how we address that for the future. So let me just focus in on pharmacogenomics, but I'll bring in some clinical factors in some of the examples that I give. So Friedrich Vogel coined the term pharmacogenetics in 1959 and said it was a study of variation in DNA and RNA characters as related to drug variation. That is, we all vary, we have a genome that varies, and if we can actually tailor drugs according to your genome, then hopefully you get a better drug response. So in the paper published in Nature Reviews Genetics earlier this year, I wanted to actually expand the definition to say there's genomic technologies to enable discovery and development of novel drugs. And following this session, there is a session from UK Biobank on how you can use UK Biobank for drug discovery and so on. And I think that's kind of pharmacogenomics as well. I'm not going to focus in on that, but going to focus in on how you can use pharmacogenomics for optimization of drug dose and choice, individual patients to maximize efficacy and minimize toxicity, whole molecular pharmacology, improve benefit-risk ratio of medicines that we use. Now, pharmacogenomic variation is very common. These are studies which have been undertaken all over the world, and you can see in the biggest studies that you find that 99% of individuals carry at least one actionable genotype or diplotype. Even the smaller studies are showing up over 90% of people. So it's likely that all of you will carry at least one actionable genotype in your genome. most of you will actually have 4 actionable genotypes in your genome. We are exposed to the drugs that have pharmacogenomic guidance. So this is data which is unpublished. We've recruited a polypharmacy cohort of 400 individuals. We recruited them in 2 strata, 5 to 8 medications they were taking, or 9+ medications. When you clean up the data and remove some of the topical medications, the numbers change. But nevertheless, you can see that this is a cohort with a huge burden on the numbers of medicines they're taking. They were all admitted to hospital. That's where they were recruited. And we are following them up through the electronic health record to determine hospital usage, further admissions, general practice visits, adverse drug reactions, and so on. And what we wanted to see is how many of these patients were exposed to drugs where there is pharmacogenomic guidance. And in order to do that, you turn to a reference product, which is the CPIC guidelines. This is the Clinical Pharmacogenetics Implementation Consortium guidelines, which are now widely accepted and highlight where there is evidence. And systematic evidence has been collected for each particular drug-gene pair to say that you can actually change dose or drug based on that particular guidance. And when we do that and look at our patients, we find that most patients are on at least a median of 2 drugs which have actionable pharmacogenomics evidence. Some patients may be up to 5 drugs that they're taking with pharmacogenomic guidance, and very few, actually the minority, are on no drugs at all which have pharmacogenomic guidance. And that's what you'd expect. It highlights that pharmacogenomic variation is common, particularly in our elderly. We are exposing to drugs which have pharmacogenomic guidance, and we don't make any changes. And it's important to remember, particularly in elderly, your reserve is lower and lower as you get older, and any small change may actually tip you over the edge and cause an adverse drug reaction or hospital admission. Now, let me just focus in on one particular polymorphism. This data is still being analyzed, and we worked with Illumina to be able to genotype these individuals. These data is still being analyzed, and we're still working on the 2D6 data. But let me take you through the CYP2C19 metabolizer phenotypes. As you can see, the minority of people were actually normal metabolizers. There were many who had 2 variants, which were loss of function variants, and intermediates, which is 1 loss of function variant, but also rapid and ultra-rapid individuals as well. And many drugs that we're taking, and these are the drugs from our patient group, are metabolized by CYP2C19. Some patients were on 1 drug, some patients on 2 drugs, and some patients on 3 drugs which have 2C19 responsible for metabolism. And when you look at these individuals who are on more than 1 drug, which is 2C19 metabolized, there's a potential in those individuals for drug-drug gene interactions going on as well. And that's important to understand, and we haven't looked at that, but we will also be looking at that in more detail. Now, if I take one example of that, which is clopidogrel, 11 individuals had polymorphisms. 2, I think, were poor metabolizers, and 9 were intermediate metabolizers, but they were taking clopidogrel for indications. So clopidogrel is a prodrug. It requires P450, particularly cytochrome P450 2C9, for its activation. And the active metabolite then binds to receptors on the platelet surface to be able to cause inhibition of platelet aggregation. Now, there have been recent randomized trial data in coronary artery disease, which have shown the utility of genotyping for 2C19 prior to giving clopidogrel. However, it's still not in major guidelines, including the American Heart or European Society of Cardiology guidelines with regard to ischemic heart disease. However, there is greater acceptance by stroke physicians in this country, and this is now the main area of implementation in the UK. I know in Tayside, in Scotland, there is people who are getting clopidogrel for TIA or stroke indication can have 2C19 genotyping done. In the Netherlands, by contrast, the stroke physicians are against the use of 2C19 for clopidogrel, but the cardiologists are taking it up very, very quickly. And importantly, recently, NICE has approved the stroke TIA indication for CYP2C19 genotyping prior to clopidogrel. And this is important because if NICE does approve it, it is important for the NHS to implement it. So the next next gene drug pair that will be implemented, the NHS, will be 2C19 for clopidogrel. However, it's also important to remember that there are some clinical factors which can affect clopidogrel efficacy as well. And this is data which has been published recently in Nature Communications from this particular group. And what they did was to look at NAFLD, non-alcoholic fatty liver disease, and they looked at various different pharmacogenes in terms of expression at mRNA level. And what they found was that 2C19 was reduced at mRNA level in different NAFLD phenotypes, that is NASH, fibrosis, etc. And then when they looked at other studies which have been published in this area, 16 studies, they confirmed that by meta-analysis. As you can see, the meta-analysis is shown on the slide. This was a decrease of about 43 to 58% in the CYP2C19 messenger RNA. Clearly it's messenger RNA, it's no protein, but there is good data to show a correlation between messenger RNA and protein with regard to CYP2C19 in human livers. This is equivalent to being an intermediate metabolizer. Now, limitation of the study is that they do not genotype individuals. They don't know how many of the individuals were intermediate metabolizer. It is possible that with that reduction, you can actually convert an intermediate metabolizer to a poor metabolizer as well. Now, there is one clinical study which shows the NAFLD patients have reduced effects of with regard to clopidogrel in terms of efficacy. And we know that in many studies, trials which have been undertaken with clopidogrel, the NAFLD patients have actually been excluded because of the various exclusion criteria which are used. So highlights that not only do you need to take into account the drug-drug interactions, the disease, but also genetics and so on, in terms of making sure the patient gets the right drug. So let me just focus in on some of the discovery work that we've been undertaking. And discovery is obviously important for efficacy and safety of medicines. However, most of the successes have been in drug safety, particularly in relation to drug hypersensitivity reactions, and this is focused particularly on the HLA locus. And the HLA locus is the most polymorphic region of the human genome of the short arm of chromosome 6, with 3 different areas, class 1, which is ABC, class 2, DR, DQ, DP, and in between is a class 3, which includes TNF, Hishok protein, and mica. And since the beginning of the century, at least 30 different HLA gene-drug pair associations have been identified. I'm only showing 24 on screen. And these affect the HLA-A region, the HLA-B region, HLA-C, DRB, DRQ, DQ, DQB1, and so on. And importantly, they affect many different therapeutic agents, and they cause many different types of adverse drug reactions, including serious skin reactions, such as toxic epidermal necrolysis. They cause liver injury, muscle injury, as well as bone marrow suppression. So increasing evidence for the role of HLA. Yet, if you look at implementation, that's slightly more difficult. So if you look at allopurinol, this is, you all know what allopurinol is, drug used for gout, but it can cause severe cutaneous adverse reactions. And these cutaneous adverse drug reactions have been found to be more common in Southeast Asia, with association with this particular HLA, B*5801 was identified. And in Southeast Asia, they've undertaken studies, prospective genotyping studies, which show that if you prospectively genotype individuals and then avoid the use of allopurinol in those individuals who are HLA-B58 positive, it reduces the incidence of scar in those individuals. As I said, the population frequency is higher in Southeast Asia than in those individuals with European ancestry, so people have debated whether it's worthwhile actually adding 5801 genotyping to our genetic test directory. And so therefore it's been variably implemented, and at the moment it's not routinely available in the UK. So here's some unpublished data in European ancestry patients that we've been looking at. And we've identified 13 cases with either DRESS, that is drug reaction with eosinophilia and systemic symptoms, or toxic epidermonecrosis or Stevens-Johnson syndrome, just 13 cases. And we compared them to 9,221 controls in this genome-wide association study. And you can see that there's one peak on chromosome 6, and when we map that, that is HLA-B star 58-1, with a massive odds ratio that you're getting on a genome-wide association study of 35.9. Highlights it's almost like a Mendelian disease, this particular association, and it is preventable by undertaking a genotyping test, which could be costing less than £100. Now, other area we've been working on is carbamazepine. Now, carbamazepine can cause various different types of serious reactions, including skin, liver, and systemic reactions. And work which has been undertaken in Southeast Asia has shown a very strong association with HLA-B star 1502. This has been replicated, and cohort studies have shown the utility of Southeast Asian patients of prospectively genotyping for HLA-B star 1502. HLA star 31-1 was something that we discovered, published in the New England Journal of Medicine, and this has also been replicated in many studies. Again, cohort studies have shown the utility of in several different ethnic groups worldwide. These particular variants are now mentioned in the carbamazepine label, in the SMPC, in the FDA label, and in various other labels throughout the world. And we, again, worked on a CPIC guideline, highlighting the need to be able to undertake genotyping in individuals who may be HLA 1502 or 3101 positive, and avoid the use of carbamazepine where there are alternative drugs available. Now, in the labels, it actually says, if you look at the label for carbamazepine, it talks about Southeast Asians. You should only do genotyping on for 1502, but it's actually quite difficult to distinguish who may be Southeast Asian because of mixed ancestry, etc. And in this guideline, we say that you should be genotyping irrespective of your ancestry or skin color in terms of preventing this particular issue. Now, if you look at implementation, that's been more difficult again. So these are 3 studies from 3 different regions, Hong Kong, Taiwan, and Singapore. In all those 3 regions, the government said they were going to pay for HLA 1502 genotyping before you put patients on carbamazepine. And that had 3 effects. The first is that the clinicians who were prescribing carbamazepine decided not to prescribe carbamazepine. And carbamazepine prescription went down overall. But where they did do prescribe carbamazepine and they did the genotyping beforehand, it actually reduced the incidence of SJS-TEN. The third thing that clinicians did was that they actually went on to the other anti-epileptic drugs, such as phenytoin and lamotrigine, and overall, the incidence of SJS-TEN didn't decrease because these drugs also cause SJS-TEN, but actually carbamazepine-induced SJS-TEN decreased. So highlighting that there was difficulties in changing behavior and introducing a genetic test in your clinical pathway before you prescribe carbamazepine, and people were substituting other drugs. Now, how can we actually start using the data that is now becoming increasingly available on HLA? And this is a study which has been published recently from South Korea. And they looked at pre-stored HLA information from transplant patients and looked at all these different HLA alleles in their database. And these HLA alleles have all been associated with serious adverse drug reactions, and many of them were mentioned in the slide I showed you earlier. And they looked at about 12,000 HLA-tested transplant recipients. 34% carried the high-risk alleles. So 1 in 3 carried high-risk alleles. And 32.8% were prescribed the risk drugs, and 4.8% experienced these adverse reactions, type B adverse drug reactions. And what they concluded was that preemptive HLA information has the potential to prevent serious hypersensitivity reactions. And we've been working on this, and we've developed an HLA genotyping panel. And this particular panel is able to genotype for multiple HLA alleles. And the idea behind the panel is that you can move from a reactive to preemptive strategy, that when a patient first attends, you genotype them for that particular drug gene pair, but to get the other HLA alleles and put them on the electronic health record. And as the patient gets older, then you have the data available to you. We worked with a company to be able to develop this, and it was funded by NIHR, and one of the stipulations was that it has to be cheaper than single locus testing. And when we've done some cost-effectiveness analysis of this panel with Dufferin Hughes, this was cost-dominant in the health economic analysis. At the moment, when I have to order an HLA test in my hospital, it takes me 2 weeks to get the results back. The important thing about this is the turnaround time is about 48 hours. And the important thing also is that this is a global panel. It covers alleles which are found in many different parts of the world, and it's also dynamic, that you can actually change the alleles as required, so that you can remove an allele or you can add an allele, etc., as needed for this particular panel. So I think this is something that's important to think about, how we actually start using HLA, make it available, and make it available for our patients as we move forward. Now, we've just, this is new data and looking at vaccine-induced thrombotic thrombocytopenia. We've just come through a pandemic, and one of the things that occurred early during the pandemic, after the introduction of the vaccines, was that the occurrence of this particular syndrome. So by 4th of August 2021, 24.8 million first doses and 23.9 million second doses of the AZ vaccine had been given in the UK. At that time, the MHRA had received 412 reports of thrombosis associated with low platelets. And when this occurred, it was important to make sure there was a clear case definition. And hematologists in this country worked very hard to have that case definition. And the diagnostic criteria were those that you needed to have thrombosis. Often it was the cerebral veins which were affected, the low flow veins, but also the splanchnic circulation was affected, and sometimes multiple venous systems were affected, and sometimes arterial systems were affected by the thrombosis. This was associated with thrombocytopenia, usually below 50, but the definition is below 150, but many of them actually went down to very low levels of platelets. And what we found was also very high D-dimer levels in these individuals, but fibrinogen was either normal or low. The hallmark of this particular syndrome was positive anti-platelet factor 4 antibody. And this, from epidemiological studies and from the sort of yellow card reports, etc., came through, was associated particularly with the first dose. And although there have been reports with the mRNA vaccines, causality has never been established with the mRNA vaccines, and most of this seems to be associated with adenoviral vaccines, the AZ vaccine, but also the Janssen vaccine, and there have been isolated reports of the other adenoviral vaccines as well that were administered to patients. So when this occurred, I set up a consortium called the Thrombotic Thrombocytopenia Consortium. And the idea behind this was to be able to undertake a deep dive in this, try to understand the epidemiology, understand the immunology of this, look at the platelet biology, but also look at the genomics. And the sort of work package 3 was led by Mark Caulfield with Genomics England to really look at the genomics of this. I'm going to show you some pilot data on the genomics. So this is the genomic study overview. So 98 participants with a vaccine-induced thrombotic thrombocytopenia were recruited. And for the whole genome sequencing, they were compared to 21,000 supercontrols undertaking genome-wide association studies and gene burden aggregate variant testing. For RNA aspect studies as well, we looked at 98 and compared them to 500 age and sex-matched controls. So if you look at the genome-wide DNA studies, the first Manhattan plot here highlights the genome-wide association study. Again, we didn't find any associations above genome-wide significance. Then if you look at the rare variants, again, nothing that crosses the threshold for significance for this. Now, this may be a power issue, we only had 98 individuals, and it is possible that there are some genetic factors you can identify on DNA. So one of the reasons for showing this is that there may be people in the audience who have identified those patients or collected DNA on some patients, and we are very keen to be able to collaborate and expand the number so that we can actually see whether there are any particular associations. Then the RNA data actually is much more interesting, the immune repertoire sequencing. And what we found is that if you look at the T-cell receptor beta chain, T-cell receptor alpha chain, and the J chain, the J segment usage for the T-cell receptor alpha, you find that there are novel clonotypes, unique clonotypes in the patients with the vaccine-induced thrombotic thrombocytopenia compared to controls. Now, I'm not showing you what those T-cell receptor clonotypes are because we are treating this cautiously at the moment. We don't know exactly what it means, and we need to be able to validate this, but nevertheless highlights the potential, and one can speculate the mechanism of this, that given that there was immune antibodies occurring, that it is possible that individuals may have particular clonotypes that are circulating in the immune system, which are recognizing the adenoviral epitopes leading to the immune response. And we have shown also as part of this consortium that if you take T cells from individuals who have had VIT, who've had VIT, but also T cells from individuals where the T cells were banked before the pandemic, you can get responses to the adenoviral vaccine, the AstraZeneca vaccine, highlighting that people have been exposed to particular adenoviruses, even if they've not been exposed to the chimpanzee adenovirus, which was the vector which was used for the adenovirus vaccine. Now, I think one of the things that is important to highlight also with regard to discovery, particularly when you have lower effect sizes, is that you can start using the fantastic resources such as UK Biobank. But you really have to, when you're doing pharmacogenomic studies in UK Biobank, you really have to pick your phenotype very carefully because it's not a deep phenotype with regard to adverse drug reactions, so you really have to pick your phenotype very carefully. So we've been looking at bendraflumethiazide-induced hyperuricemia and hyperglycemia, and this paper's under review for this particular study. We know that if you look at sort of urate levels and you look at blood sugar levels, and people have done GWAS on those, and there are well-known genetic predisposing loci for those particular phenotypes. And the question we asked was, does bendrafluozide have genetic predisposing loci over and above those seen without drug exposure? So we undertook analysis in UK Biobank and about 20,000 individuals who were taking bendraflumethiazide compared to other individuals who were on other antihypertensives. Undertook gene-environment interactions following variant QTL analysis, and we were able to identify that there was one particular locus on CDKAL1 for glucose and SLC2A9 for urate, which were particularly associated with bendraflumethiazide-induced hyperglycemia and urate. We will need to do mechanistic studies to be able to prove the mechanism of that, but nevertheless highlights the potential utility of using large databases like the UK Biobank to be able to look for novel associations. So let me just go on to implementation. I've already highlighted how implementation can be difficult in many circumstances, and there are many issues associated with implementation. If you look at the literature on pharmacogenomics and implementation, there are 40 distinct programs going on in the world at the moment. Most of them are in high-income countries, 95% mostly in the United States. And all people are using different paradigms to be able to do this. And when I was president of the BPS, I worked with the Royal College of Physicians, and people like Mark were involved in the committee. And we set up a committee with the Royal College of Physicians. The Royal College of Physicians in the UK represents 26 medical specialties. But we also invited the Royal College of Anaesthetists, Royal College of Child Health to this, and Royal College of Psychiatrists to this committee. And what we looked at was the evidence base for pharmacogenomics and published this report called Personalised Prescribing, which is available on the BPS website or the Royal College of Physicians website. And the recommendations from this report were that we are in a position now, given the evidence base out there, to implement pharmacogenomics in the NHS in all sectors, that is primary, secondary, tertiary care. And in order to avoid the postcode prescribing that sometimes occurs, that this should be centrally funded so it's available to anybody who requires it. We also recommended that any kind of system that was set up would have to be co-designed with patients, but it would have to be agile. It's responding to advances. There are many advances going on in this area, and we need continual evaluation of this. We need continual evaluation not only to add new things, but also take things away based on further evidence that occurs. Unfortunately, there's a major skills gap in our healthcare workforce in terms of pharmacogenomics, so this all needs to be accompanied by a comprehensive education and training package. But even with the education training, not everybody will be able to carry all the pharmacogenomic evidence in their head, and we need IT support for this, and therefore intelligent decision support systems are going to be critical in order to make sure that we can implement this safely. And clearly further research is still needed in this area. And importantly, there needs to be clear lines of communication for healthcare workforce, but also for the public and patients as well, in terms of the benefits, advantages, as well as the limitations of pharmacogenomics. And so this paper was published end of last year. Since then, we have had this particular paper which has been published in the Lancet, and I was involved in this UPGX consortium. Now, it was discussed yesterday at a symposium on pharmacogenomics by Erica Chekin, so I won't go through it in detail, but what this highlights is the primary analysis. This study was undertaken in 7 European centres. In the UK, Liverpool was the UK centre, so 7 EU centres, and Liverpool was the UK centre. So the primary analysis in the actionable test result cohort highlighted that the potential of 30% reduction in adverse drug reactions through a single intervention in patients' 12-gene pharmacogenomics panel. The health economic evaluation for this being carried out at the moment, but again, it adds more evidence to the fact that pharmacogenomics is ready for prime time. Now, let me just turn on to another area which I think, and we are working on this, which is really important, is the lack of diversity in genomic studies. So if you look at the GWAS catalog, and this is data published in Nature Genetics, shows that 97.4% of all GWASs up till 2020 were carried out in European patients. Only 0.02% were in Africans, and only 0.02% were in Afro-Caribbean or African-American individuals. Huge lack of diversity, but fortunately this is being addressed. This is being addressed, for example, in our Future Health here, where there's increased recruitment of different ethnic groups, but also by the All of Us program, and very grateful to Sarah Van Drist for sharing these data with me from the All of Us program. And these are data which has just been available on the website, which highlights the fact that the All of Us program has been successful in being able to recruit individuals of different ethnic groups apart from European ancestry individuals, and the genomic sequencing has been undertaken in those individuals, and the data is becoming increasingly available. And there are other programs which are all around the world which are actually trying to increase the diversity in genomic studies. And this is important, and let me just give you one example of that. And if I just go to warfarin, which is a very well-known anticoagulant, and if you look at the variants which are available, so if you look at STAR2, cytochrome P452C9 variant, STAR2, STAR3, these are the European ancestry variants. And these are the variants which have been particularly utilized in pharmacogenomic studies for warfarin in the dosing algorithms which have been developed. However, the African patients do not have STAR2, STAR3 variants, but they do have the STAR5, STAR6, STAR8 variants. And as you can see, the effect of those variants on warfarin dose requirement is equivalent to that of STAR2 and STAR3. Yet these have not been included in any kind of pharmacogenomic algorithms and any trials so far which have been undertaken. Important because warfarin is the only drug that can be afforded at the moment in many low middle income countries and has not displaced DOACs. And if I just turn on to that, if you look at sub-Saharan Africa, there is an inability to perform not only DOACs, but also inability to perform genomic testing. the anticoagulant services are poorly developed because of lack of infrastructure. And the quality of anticoagulation is unfortunately poor. And part of the problem is that if you look at the GDP compared to the United States, it's really very low, hence the inability to be able to afford some of these expensive drugs and so on. So we wanted to be able to look at this, and we formed this particular consortium called Warpath, and the full title's there, again funded by the NIHR and the UK. And Katrina Waite, who's in the audience, was part of that consortium, as well as Karen Cohen in South Africa and various other colleagues who worked very hard with me on this particular consortium. And I'm going to just show you one aspect of this, or how can we actually start to tackle some of these things without actually necessarily introducing genetics, but actually looking at the variation in healthcare systems, but actually using clinical pharmacological principles to be able to improve the anticoagulation in some of these countries. And so what we did was to introduce something called the warfarin bundle. It's a complex intervention, and the complex intervention is in the orange box. And this centers around process-centered activities, where we develop guidelines and governance approvals in order to be able to use particular algorithms. And we also introduced point-of-care INR testing. The problem with INR testing in many of the clinics that we visited was that it was available, but not all the time, and the patients had to wait a week to get the result back, etc. By having point-of-care INR testing, you actually take an opportunity to be able to educate the patient on the drugs that they're getting, the warfarin that they're getting, and what the result means. The patient-centered activities included a clinical algorithm. One of the clinics that I visited in South Africa had a whiteboard with the sort of dosing that they were using, etc. But it was empirical, and there was no clear rationale for how that algorithm was developed. So we recruited about 700 individuals and developed a clinical algorithm, which we validated and then implemented as part of this warfarin bundle. As part of this, adherence was really important. Again, Garrett Fitzgerald mentioned the importance of adherence, and adherence education of patients, adherence education of healthcare professionals to keep on reminding patients about adherence was an important part of this bundle. And then when adverse events did occur, we undertook a root cause analysis. And so what we did was test this out in 2 centers, in Cape Town and in Kampala. This was a prospective recruited cohort compared to historical controls. The aim to determine the primary outcome was whether anticoagulation control improved after 12 weeks. And the idea behind this pilot study, if you like, is that if this works, then we would actually undertake a randomized control trial in a larger number of countries, which will be our next step. And so the results of this have not been published, but have just been analyzed, and the health economic analysis is going on, and the results from Uganda and South Africa are shown in different tables. The important thing to remember, look at this, is that in retrospective, you can see that 14 days between INRs, but much, much shorter within the sort of prospective arm, and you can see the percentage time in range went up to about 38% the prospective arm, 30%, and South Africa 39% compared to 25%. Again, and these were statistically significant, highlighting the warfarin bundle was having an effect, and what we now need to do is to actually show the utility of this in a randomized controlled trial, which is something that we are planning right now. So let me finish off by 3 slides. William Osler highlighted the importance of variability and said variability is the law of life. However, even before William Osler, Hippocrates has already defined what precision medicine is, really. What sort of person has a disease than to know what sort of disease a person has. An important aspect in pharmacology is the dose, and Paracelsus defined the dose is either the remedy or poison. Unfortunately, we haven't really learned from what Paracelsus said 500 years ago, and we do need to do that. And hopefully I've shown you that there is variability to response. It's complex. I've not talked about many other areas, such as human exposome, but healthcare infrastructure can affect variability in response, clinical factors that are covered, and genomic factors. And we need to be able to take all of that into account. And really, and I think the important purpose of clinical pharmacology is always to improve the benefit-harm ratio of medicines. To do that, we will need to deal with complexity. Currently, in most cases, we deal with one factor at a time, but most patients we see have multiple issues which need to be evaluated and controlled. Now, in research, we have fantastic new technologies, new techniques which are available for us to be able to deal with this complexity. Unfortunately, how are we going to implement the complexity into clinical practice? And implementation science, as again, agreeing with Garrett, is really important, thinking about how we're going to implement something like complexity to try to improve what we do for our patients. So let me finish off by thanking all the colleagues who work with me at the University of Liverpool, plus many others I haven't been able to put on the slide, many of the funders that have funded our work, and the UPGX Consortium, Horizon 2020 funding, and also the Thrombotic Thrombocytopenia Consortium, and obviously thanks to Mark for leading Work Package 3 that I showed you data on, and the NIHR Global Research Group on warfarin, Katrina Waite and Karen Cohen, as I mentioned, and plus many others. So thank you very much for your attention.
Thank you for an exceptional introduction to day 2. Are there questions for Munir? Please come to the microphone. Yes, please.
Hello. Good morning, Munir.
Hi.
Nice. Very insightful talk. So my question, I have 2 questions. First of all, so how this drug-induced side effect or non-response, what is the percentage on the current prescription drugs? I mean, genomic associated variants, cause the side effect or non-response. Yeah.
So it varies between different drugs that you'd expect. Some drugs have very low genomic effect, while other drugs have a very large genomic effect. And people have tried to estimate, and people have suggested maybe 30% of the effect of a particular combination of drugs may be related to genomic factors.
30%?
Yeah.
Okay.
People have suggested that, but again, the evidence base for that is not particularly good, but it does vary, and it depends on drug, depends on individual.
I see. And the second is about vaccine-induced VITT. Okay, so you're showing maybe it's due to the power, population power 98 patient.
98 patients, sorry.
Included. So far you haven't identified any of gene variants associated with VITT, but indicate something wrong or something wrong with the T cell function. Is that right?
That's right. So what we're identifying, and again, it is, I don't want to be too speculative, and we do need to validate this, as I said, but there does seem to be different T cell receptor clonotypes in individuals with the vaccine-induced thrombocytopenia compared to individuals who didn't have that.
So maybe more associated with adenovirus plasmid rather than messenger RNA vaccine, right?
So the epidemiological studies show that the vaccine-induced thrombotic thrombocytopenia has been associated with adenoviral vector vaccines, AstraZeneca, Janssen, plus the other adenovirus vaccines, but has so far not been associated causally with mRNA vaccines.
Okay, thank you, Mira.
Okay. We'll go to number 4, please.
Thank you. Thanks for a very nice talk. My name is Badri from Chulalongkorn University, Thailand. I actually have 2 questions. The one is quite naive. Can you explain more about the mechanism between the HLA causing the side effect from drugs? And the second question is, can you comment on the role of long-read sequencing of the HLA and the clinical implementation? Thank you.
Okay, thanks very much. So we know for some drugs at least, what the mechanism is. And what we find is that the variation in the MHC, the HLA, and the T cell receptor, and the drug is able to bind in immunological synapse in certain individuals and leads to the T cell receptor proliferation, T cell proliferation. The mechanism by which the drug binds to form the immunological synapse varies according to different drugs. In some cases, it may be related to metabolite. For example, with penicillins, you have a beta-lactam ring, which is chemically unstable, so you actually get metabolite which is responsible. For other drugs, it seems to be the parent compound which is important in forming the immunological synapse. The second question about long-read sequencing, the HLA panel that I showed you is direct typing, genotyping. Some people use tag SNPs for determining HLA type. The problem with tag SNPs is that they may work in one ancestry but not in other ancestry. Now, people have used short-read sequencing and developed algorithms to be able to call HLA types, but again, there may be some issues with that. And obviously, long-read sequencing allows you to be able to phase and look at haplotypes much more clearly and so on. But actually, at the moment, the long-read sequencing is very much a research tool for this, but direct typing is still available and probably the cheapest, and the turnaround time is important, as I said. When I talk to physicians, would you use HLA genotyping, epileptologists I talked to, and they said only if the result was available 48 hours. That's why we worked on a test which was available 48 hours.
So we go to number 1 and then number 3. So you're first.
Munir, hi. Kathy Giacomin, UCSF. Munir, really great talk, as always. So you brought up the issue that plagues, I think, all of us in pharmacogenomic research, and that is power, the numbers. We need to expand, we need to form consortia, we need to do everything. And one of the reasons is we're seeing a sort of, if you will, polygenic risk factors. So you didn't address that, and I'm wondering what your thoughts are about polygenic risk scores in pharmacogenomics, especially for those with multiple signals, and how that might change.
Yeah, so we are starting to look at polygenic risk scores, particularly where we can't find large effect size single variants or a couple of variants and so on. But even when you do find those, the important thing also to maybe to look at and evaluate whether you can actually use the variants which have a large effect size and then combine them with other variants which have lower effect sizes and so on. I guess the issue is that there have been, as you know, in the literature, and there was a sort of talk on that yesterday, symposium on polygenic risk scores in drug-induced liver injury. The problem is that how are we going to implement that? We're having difficulty implementing single variants into clinical practice, or even 2 variants in clinical practice. How are we going to implement something like 1 million variants which are causing a polygenic risk score, and so on? So I think that is something that we do need to look at and understand the utility, but also the cost effectiveness of being able to do that and so on. And I know that there is a much more work going on in polygenic risk scores in complex diseases, but even complex diseases, I think they are way behind in terms of implementation at the moment. If you look at breast cancer screening for mammography, where there's very good data now showing that you can actually stratify people who need to have mammography with breast cancer screening, they still, when I asked Doug Easton, who leads something, he said still years away before we actually implement something like that. And the other issue, obviously, with polygenic risk scores is ethnicity. Majority of data we have is European ancestry patients, and it's not portable between different ancestries.
Yeah, absolutely. Okay, great. Thank you.
Number 3.
Thank you, Saad Shakir from the Drug Safety Research Unit in Southampton. Thank you very much, Munir. Yet another brilliant talk. I don't know how you have the time to do all these things. Still drive your wonderful cars. My question is, you mentioned that in addition to the genotype, there could be other factors. And I wonder whether they can be clinically used. I give you the example. Tacrolimus and ketoconazole, it's an interaction which increases the levels. I know that in low-income countries in Africa, doctors use a smaller dose of tacrolimus because it's expensive, and they give the patients intentionally ketoconazole to increase the bioavailability of it, to make it clinically useful. In all the examples you gave, are there any clinical strategies to influence the environmental factors so that we don't have black or white, yes or no, give this drug or don't give it? Are there any strategies which are being used for some of these genotypes variations?
So people have tried to actually, when you've got an expensive drug, people have tried to give concomitant enzyme inhibitors because of the cost and so on, so you can reduce the dose. And that was actually started with cyclosporine because cyclosporin, when it was first introduced, was very expensive. So people started looking at 3A4 inhibitors and in fact started using grapefruit juice. The problem was the grapefruit juice varied in the content of 3A4 inhibitors. Maybe it was more, you have much more 3A4 inhibitors in Harrods grapefruit juice compared to Lidl's grapefruit juice, I don't know. So it was quite variable, but people started using that. And again, I guess that also has been used, that combination has also been used in HIV very, very successfully, where you inhibit P-glycoprotein in the gut to allow absorption of the 3A4 metabolized drugs, anti-HIV drugs, to get into the system. So those systems are being used, but I agree that there are other areas where we can look at much more detail, whereby we can use those kind of potential ways of being able to improve drug therapy.
Thank you.
It's a very final question on number 1.
Hello, good morning. I'm Chris from King's College London. So thank you for a very insightful talk. So one question for me is that, so far in the talk, we have seen a lot of evidence in terms of using pharmacogenetic panels to prevent medication-induced adverse events. But in certain papers, like a prepared trial paper in Lancet, they also talked about the effect sizes of these implementations could be somewhat deflated because there are some sort of augmentation of treatment response that we could also leverage from using these kind of pharmacogenetics panels. So do you have any thoughts on how we can move forward as we use these pharmacogenetic information in augmenting treatment response to a certain drug or a certain drug class? So thank you.
So thanks very much. So obviously the implementation is important and implementation has to be done safely. And as a result of some of the work that's been undertaken here, the Royal College of Physicians report, as well as the sort of PREPARE study, we are now undertaking an implementation feasibility trial study in Northwest. Manchester is leading it together with Liverpool, whereby we're actually seeing how safely we can actually integrate pharmacogenomics into the National Health Service. The most difficult aspect of actually implementing pharmacogenomics is actually integrating within the NHS, working with the electronic health record system so that it's implemented properly, integrated properly within the sort of clinical pathways. Genotyping is no longer a problem. Identifying some of the evidence is no longer a problem, but actually integrating it into the healthcare system is a difficulty.
Okay, thank you.
Thank you. Okay, ladies and gentlemen, there's now a refreshment break till 9:45, and then parallel sessions across the Congress halls will re-begin. Thank you all for coming along this morning. I'll let it overrun, but when you get this man on the podium, you've got to extract every ounce of value from him. So thank you, Munir, for a wonderful talk. Thank you.